One.
Online.
Online. So good afternoon again. We're on behalf of Dr. Zampogna, Dr. Parisi, Jacopo, myself. We want to welcome you here, and we are very appreciative of the morning, afternoon, evening, night that you folks are presenting to us from. We have a room full of anxious people who would like to hear about POCUS and have been looking forward to this for a few weeks. So we're going to move forward as much as possible to try to create a little time for questions and answers and discussion. So Thomas, I'm going to ask you to introduce yourself just in a sort of a 1-minute intro of yourself. And then if you can go ahead and move on to your presentation on your first presentation.
Sure, I'd love to. First off, thank you to everyone for inviting me. I'm glad to hear of all the interest in point-of-care ultrasound that is going on. My name is Thomas Conlon. I am a pediatric critical care physician here at the Children's Hospital of Philadelphia. I am the director of our pediatric critical care point-of-care ultrasound program, where we train fellows and residents and faculty in learning critical care ultrasound. We also host a number of courses, both here in Philadelphia as well as across the country, and associated with some other conferences in teaching point-of-care ultrasound for diverse learners. The talk that I was asked to give to begin this webinar was in really focusing in diagnostic point-of-care ultrasound. I recognize that many of the learners that are there may be unfamiliar with point-of-care ultrasound. Some have some experience in point-of-care ultrasound. And obviously there are a number of different applications that we can use in diagnostic ultrasound, far more than what I can fit into 15 minutes. So what I'm going to try to do is talk about how we can understand what applications we should be using in our specific clinical practices. I don't have any disclosures really for the group. So the objectives of this talk are to define the context of where we practice medicine individually and as a group, and to understand competencies or the applications of diagnostic point-of-care ultrasound and our own competency in how we perform diagnostic ultrasound, and to discuss how those three things really influence each other in translating education to our clinical practice. I'm going to also discuss why diagnostic ultrasound competencies or applications are really context dependent. It really is dependent upon where you practice and what type of medicine you practice to define what it is that you do in the clinical setting. And I'm going to really focus in on lung ultrasound because in particular, lung ultrasound is something that in Italy is emerging, and not just emerging, but is very well done and is advancing at a rapid pace. And I know that you're going to have a lecture shortly on lung ultrasound in your clinical practice. And I'm going to describe the structure by which you can identify competencies that are going to be relevant to you in your clinical practice. So when we think of diagnostic ultrasound, we think about moving beyond just procedural ultrasound. As you can see on this left picture, this is somebody who's placing a needle into a blood vessel through a mannequin trainer, teaching themselves the proper way of using ultrasound for procedural success. You can also incorporate your knowledge of anatomy in helping you with your procedures. So this is a neonatal patient who is requiring a lumbar puncture. And you can see coming from the left, the conus, as well as the cerebral spinal fluid that you will be acquiring during your lumbar puncture. So many of us start ultrasound with procedural applications, but we learn that once you understand procedural applications, we want to learn more about diagnostic applications. We want to be able to see the heart because so many of our children present with pathophysiologic processes in their hemodynamics. We want to be able to look into the abdomen and look in blunt trauma patients for any evidence of bleeding. And for the child who has hypoxemia, I want to be able to diagnose pneumothorax so that I can target a therapy or a procedure very rapidly to save that child's life. When I talk about competences or competencies, I'm talking about really the applications that we learn in our respective practices. It's the development of skills that have certain standards. It's the things or the applications that we need to learn as clinicians. And we need to learn them because, first, it makes us better as clinicians. And second, it improves the care that we provide to our patients. So when we think about diagnostic applications, what should we be learning? There are really two ways of trying to identify this that are really the standards. We look at experts in the field and we ask them, what are the things that are important in your clinical practice? Or we can rely on data and look at our literature and say, what are the impactful applications that are really driving better outcomes? Guidelines are actually wonderful sources for helping us to identify diagnostic applications because they try to blend expert opinion with the current data. And for my profession in pediatric critical care and in neonatology, a group of individuals came together and developed international guidelines for diagnostic applications. Now, when I'm specific to lung ultrasound, you can see that we have 11 different applications, 9 of which are diagnostic applications. And I'm not going to go through each one of these, but you can see that there is expert agreement, and then there is the data that supports those statements. And so these European Society of Pediatric Neonatal Intensive Care guidelines identify a few things. So they identify that providers should be able to describe respiratory distress syndrome, transient tachypnea of the newborn, meconium aspiration syndrome, pneumonia, acute respiratory distress syndrome, pneumothorax, edema, effusion, atelectasis. Many of these with strong expert agreement, but maybe without great data to support them. Anytime we interpret guidelines to help drive what we are supposed to do, we have to ask a couple of questions. First, are those guidelines methodologically appropriate? And I think that we were pretty robust in developing these guidelines from a methodologic standpoint. And another question you should ask is, how do we define those experts? So for these guidelines, we had 19 individuals that came together, but none of those are emergency medicine experts. And really, is 19 individuals sufficient for describing what we should be doing around the world in point-of-care ultrasound? And the next question is really, how do we account for our individual context of practice? Because we know that context of practice matters, meaning where you are or where you practice medicine influences what you do or the competencies that you are supposed to perform. So I can talk a little bit about myself and then of my practice. So I am a pediatric critical care provider. This means that I don't really encounter respiratory distress, transient tachypnea of the newborn, meconium aspiration. And different from my emergency medicine colleagues, pneumonia and bronchiolitis as a diagnosis become sort of irrelevant in the ICU. But I am interested in the physiology of respiratory disease. I also work in a quaternary care hospital, which means that I have radiology support 24 hours a day and 7 days a week, which also may change what I do using point-of-care ultrasound. And finally, I work in the United States, where we have specific credentialing requirements for use of new technologies in our clinical settings. And we also have different medical legal considerations than those others who are providing care around the world. So this is my context. And this is why it's relevant to what I do using point-of-care ultrasound. I have my own sort of criteria for identifying a POCUS competency that is relevant to my clinical practice, whether it's in hemodynamic assessment, respiratory or lung assessment, or abdominal assessment. I want a disease or a pathology that is either frequently encountered in my clinical practice, or it's lifelong, where I make an intervention and I may actually improve the child's outcome. I want it to be amenable to my ultrasound interrogation. I want discrete, qualitative, or semi-quantitative measurements, meaning a pretty simple assessment. Is it present or absent? Is the dysfunction moderate or severe? Or is it normal? I also want my competency, or the skill that I develop, to be following brief training. I don't want to have to take a 3-year fellowship to be able to answer a relatively simple question. And I also want something that is impactful in my clinical management. So I think of competencies, or what we should be doing as clinical care providers using ultrasound, as sort of a continuum. That we need to think about the diagnostics of things, the respiratory distress syndrome, the bronchopulmonary dysplasia, bronchiolitis, and pneumonia, pediatric ARDS, asthma. But we also should think of those diagnoses as a physiology. So here, you can see a picture, right? And this is of a consolidated lung. And I know that I want to improve this picture and this clinical condition, and I can do this by making an intervention. And that intervention should change my physiology. And I can visualize this change over time. And with further interventions, I should see continued clinical improvement, not only in the clinical context of the patient, but also through images. Beyond just describing the pathology that we see, sometimes we can actually put numeric values to them. This is a lung ultrasound score, for example, where a score of 0 is good aeration, and a score of 3 is a consolidated lung with that infusion that's around it. And so quantifying things can also allow me to assess my clinical improvement and my response to therapies. The neonatal literature has really showed us how we can use ultrasound to not only make a diagnosis, like here in respiratory distress syndrome with a paper published in 2008, but also predicting the need for therapies in certain subpopulations, like they did with the need for surfactant in that patient population in this pediatrics manuscript in 2018. And not only can they identify the need for therapies, but also the responsiveness of therapies, which we can see in this manuscript from CHEST in 2021. And obviously, these are all being led by these incredible Italian physicians who are in neonatology. And again, with colleagues such as yours in emergency medicine, really driving things in lung ultrasound. For me as a critical care physician, I have slightly different questions. Can I predict extubation readiness using lung ultrasound? Can I monitor and modify my treatments to patients with pediatric ARDS? And there's emerging literature that tells me that these are applications that are possible for me to do. When we think about the applications that we start with as emergency physicians or critical care physicians, we have to start somewhere. And it's good to think of ultrasound as a beginning with their applications. But remember, for something like lung ultrasound was actually supposed to be impossible to do. This is actually written in textbooks from 20 years ago. But we know that lung ultrasound is not impossible. It's actually really important to actually improve our patient outcomes. And not only is it important for us to learn, but there's always going to be new processes that we encounter in our clinical practice that are going to be important for us to apply lessons learned to. So defining competencies shouldn't just be a beginning. It also should not be an end. We should be thinking outside the box about applications that are going to be novel as we move forward in caring for different patients. So competencies are the things that we need to do, or the applications that we need to learn. Competency is the development of that skill as an individual, or the behavior of individuals to integrate those skills in practice. This comes with certain qualifications that you might need to meet, and it's defined by a capability or a threshold that you can attain to demonstrate that you are capable or have sufficient skill in the practice that you're trying to accomplish. So as I put those three words together, really where you are or your setting of practice, like as a pediatric emergency physician, is really going to influence what you do using point-of-care ultrasound and how you do it as far as developing your competency. So another thing that I'm interested in is, well, once we identify the things that you should be doing, how do we train you in how to do them? And there are known domains of learning that I think are relevant to ultrasound, specifically cognitive domains of learning, or your knowledge base, and the psychomotor skill that you're going to learn, meaning utilizing your motor skills and applying them in the clinical context. I think ultrasound has a unique domain of learning as well, that of an interpretive domain, where we integrate pictures with our clinical assessment at the bedside of a patient to drive the therapies that we think are going to improve our outcomes. When we think about ultrasound education, we need to recognize that very little is known about the optimal methods of training individuals. We're still in the early years of understanding ultrasound and where it's best utilized in our clinical settings. We need to recognize that there are no validated methods of measuring competency and no widely accepted thresholds to identify that competency once it's been developed. There are many opportunities that exist in ultrasound education research. So in conclusion, I think that diagnostic, physiologic, and therapeutic ultrasound applications should really all be considered competencies and things that we strive to better understand when we use point-of-care ultrasound. That the applications that we learn need to be contextual. Thus, it is not only difficult, but it's actually impossible to designate a core set of competencies across all of our practice settings. And we should not limit providers from exploring new methods of assessment using diagnostic ultrasound, but really need to define and ensure competency in our clinical practice. I want to thank you guys all for your time, and I'm happy to answer questions once these initial lectures are done. Thanks.
Thomas, that was great, and I'm going to ask you a question or two while Carolina is uploading her slides. Thomas, that was a great overview, and it seems like there's such a lot that can be done with diagnosis. But one of the questions is, when starting out, sometimes ultrasound seems to show us the obvious. So if you were to pick sort of one aspect of diagnostic ultrasound that you think would be like the best or one of the best to start with, maybe one or two, what would you pick for this group here? That most of which I think are not so used to using ultrasound for diagnosis.
Sure. I think that I would give you two answers to that, and I have slightly different answers for reasons for them. The first one is, I think lung ultrasound is a very simple task, and it is not very controversial, meaning that in the United States, at least, not many radiologists will perform lung ultrasound to look at disease states. And obviously, cardiologists will not need to use that. So that is really a practice that can be very specific to your local area. And also, I would say in Italy specifically, that there are people who are very well trained in lung ultrasound, and there are opportunities for research and for moving forward from a programmatic standpoint and really developing that skill under the supervision of people who are knowledgeable about it. The second answer I would give is, if you had one place that you could look at with an ultrasound, it would be a subcostal view. Because if you place a probe and look at the subcostal region, you can look at an inferior vena cava and an aorta and you can get a sense of whether or not a child needs to have fluid administered to them. And if you fan the probe down, you can look up at the heart, and you can identify the gross function of the heart. This can be used in many different clinical situations, from the patient who comes in with dehydration on their chest x-ray, to the patient that you're worried about a pericardial effusion during a cardiac arrest. And so that one view will give you a lot of information. You can't take too much from that view, but you can answer some very simple and very important questions about your patient by learning those images and knowing the strengths and limitations of those images.
Terrific. And then the second question I'm going to ask you before we move on is for the relatively novice operator, what do you think is sort of the most common mistake that we make with lung ultrasound? Like, what overcall do we make, or is there a particular thing that you just see recurrently, the error that the novice POCUS player makes when they're starting out with ultrasound of the lung, diagnostic ultrasound of the lung?
Yes. So the most common mistake that I see is that the probe, instead of being directly perpendicular to the surface, is actually off at an angle. And the thoracic cavity is rounded. And so your best image, it's called the angle of incidence, the best image that you're going to acquire is directly at a perpendicular plane, because all of the ultrasound waves that are emitted are going to come back and be received by the ultrasound.
And Thomas, what does that create? What does that, how does that create misdiagnosis?
It can create, it will preclude you from seeing many of the artifacts and many of the pathologies that might help you in guiding either your diagnosis or in assessing your treatments over time and what impact they are having on your patient.
Terrific. Well, I think we're going to go ahead and move on to Carolina. Carolina, if you just, I know a lot of people here know you already, but if you can just give us a 30-second introduction to who you are and then move on with your presentation. You might still be muted, and I'm not sure if that's Jacopo or you.
I do have a question. Why?
For Thomas? While we're working that out, why don't you come up here and just listen to Carolina. Thomas, we're going to have another question for you where Carolina is finding her voice.
If you have a problem with your mic.
Yes, go ahead.
Hi. I'm asking you if, in your knowledge, there is any application for lung ultrasound for congestive heart failure.
So the question, as I understand it, is the use of lung ultrasound for congestive heart failure.
Yes.
So there is very good adult literature that allows us to differentiate between congestive heart failure and patients who have COPD or chronic obstructive pulmonary disease. So that is in the adult literature.
Oh no.
We do have different processes that create cardiac dysfunction, such as myocarditis, such as septic shock, chronic congenital heart disease. And so can identify this with lung.
Thomas, we're having trouble hearing you. You're intermittently coming out. Can you speak in sign language, please?
All right.
And Carolina, you have your phone microphone is off. For that reason, we don't. Okay.
No.
Oh.
What I'm going to do is ask Anna Maria Mussolini to step in. Anna Maria, are you ready to go with your presentation? We're going to go out of order, if that's okay.
Okay.
Perfect, we can hear you. If you can, also, you're well known here as well, but if you can just briefly introduce yourself for 30 seconds and then move on with your presentation on point of care ultrasound. Are we ready?
Okay. And good evening to everyone. I am Anna Maria Mussolino. I am an emergency pediatrician in the emergency department of Pediatric Hospital Bambino Gesù. And now I am the responsible of pediatric ultrasound study group of the Italian Society of Pediatrics. And I would like to thank Dr. Pagani and Dr. Zampogna and Professor Naccarni, and in particular, Professor Colum. 3 years ago, I had the great honor to be in Philadelphia, and his critical ultrasound center, thanks to Naccarni, I went to Philadelphia, and the critical ultrasound center directed by Professor Colon, it's one of the most important realities in the international field. But I may begin, Jacopo. I had to share, or you?
No, I share, but you are not in presentation.
Okay. Che devo fare? What I have to do?
Present your slide on your computer.
Okay.
Perfect.
Okay.
Yes.
Is it okay? Okay.
Yeah.
And so, this is the question for your point of care ultrasound in pediatrics. Are we ready? And I think this is the right moment to state that we have to start to believe and use POCUS in pediatric emergency. But what is point of care ultrasound? According to the definition of Professor Marin in Pediatrics 215, point of care ultrasound is a bedside technology that enables clinicians to integrate clinical examination findings with real-time sonographic imaging. And the sonographic imaging are obtained by the physician himself. And why we like to use bedside ultrasound? For rapidity of execution bedside in emergency and in any other setting to complete the clinical evaluation. And it could allow greater diagnostic accuracy. And it's a tool for rapid monitoring of therapeutic effects because it is quick, simple, repeatable. And in selected cases, in monitoring and follow-up, it may allow less recourse to chest radiography and CT. And particularly important in pediatric age, protection is advantageous. But it's very important, and especially for the younger, that it is to complete the clinical evaluation, not substitution. And I want to begin with this review article published in the New England Journal of Medicine 2011. And then the same review article, but 10 years later. 10 years ago, it's written the concept of an ultrasound stethoscope is rapidly moving from the theoretical to realities. And then there is a need to ensure competence. And Professor Colum told us much about competence. And what happens 10 years later? The definition. Point of care ultrasonography is defined as the acquisition, interpretation, and immediate clinical integration of ultrasonographic imaging performed by a treating clinician at the patient bedside rather than by a radiologist or cardiologist. And POCUS is an inclusive term. it is not limited to any specialty, protocol, or organ system. And 10 years ago, it's written especially for fast examination, and the conclusion were the use of point-of-care ultrasonography will continue to diffuse across medical specialties and care situations, and it's written future challenges. And this is what happened about evolution of point-of-care ultrasonography during the past decade. And in 2021, POCUS examination for clinical monitoring, especially for acute respiratory failure, hemodynamic failure, resuscitation from traumatic shock, and POCUS assessment of patients with decompensated heart failure or coronavirus disease, and even use of POCUS during the standard CPR sequence, during the brief periodic interruption of chest compression, particularly with subxiphoid views. And look at this number. Sensitivity and specificity for acute pulmonary edema, pneumonia, pneumothorax, left ventricular dysfunction, thoracoabdominal trauma. And this is true both for the adult and for children. And the conclusion in 2021, the use of POCUS is not limited to one specialty, protocol, or organ system. And POCUS will become a standard tool for the frontline clinician. And let's go back rapidly to ultrasound history. In 2015, Professor Marin wrote in Pediatrics, as much as it is our responsibility to understand the limitations and challenges associated with integrating point-of-care ultrasound into pediatrics, and it is our responsibility, our patients, to stay abreast of the most current advance in medicine. And point-of-care ultrasound can help us meet this goal. And these are 10 important applications of point-of-care ultrasound in pediatric emergency medicine, 2018. And this is very important paper from Professor Collor, but he will tell about this. But it is very important application of point-of-care ultrasound pediatric practice. And 2018, Pediatric Clinics of North America, they wrote that POCUS examination in pediatric emergency medicine is one of the recent advances in application to pediatric emergency care. And I would like to invite you to read this 15-minute consultation using point-of-care ultrasound to assess children with respiratory failure, because we can read many benefits, but also some drawbacks. And especially when we use a new technology, it's our duty for us, for our patients, it's our duty to know the pros and the cons. And conclusion, POCUS is an essential skill in adult emergency medicine and critical care. This should be the case in pediatrics too. And now, the crucial point of the presentation, the reason why we must be ready. European Resuscitation Council guidelines 2021 for pediatric life support in the assessment of seriously ill or injured child. They recommend, when you are checking for breathing, to consider, together with all the parameters, all the clinical evaluation, to consider thoracic ultrasound. And it's the same when you are checking for circulation. Consider point-of-care cardiac ultrasound. And why? Because POCUS has at least similar sensitivity and specificity to check for diagnosing childhood pneumonia, and is more accurate for pleural effusion or pneumothorax. And this is the same for POCUS for circulatory failure, and Professor Colon tell us later. So going on our pediatric advanced life support examination of the patients in critical condition, we begin with the triangle of the general appearance, then sample, and then our clinical examination according to A, B, C, D, E, path, together with ultrasound examination. And in particular, when we are assessing B, we had some questions and some answers. Are there large pneumonia? Is there pneumothorax? Is there large pleural effusion? And only few minutes to answer yes or no. And going on, circulatory assessment, is there inferior vena cava enlargement or large pleural pericardial effusion? Or how is left ventricular contractility? And is there large pleural effusion? And if this is important when you make your first check, this is more important when you make your re-evaluation with the same questions and the same rapidly answers. And it is important, and Professor Colon will explain later, when you are giving fluid in any kind of shock. And maybe we can use POCUS also when we are checking for reversible shock causes. And we have very, very few minutes to answer to some rapid question. Are there ultrasound sign of hypovolemia or tension pneumothorax or cardiac tamponade or pulmonary thrombosis? And only 1 minute, but I think it's due. Bedside ultrasound, particularly lung ultrasound, has proved particularly useful during COVID-19 pandemic, not only for adults, but also for pediatric population. And for the possibility of carrying out exam directly at the patient's bed, and for the ability to quickly identify if pulmonary involvement is present in a child with COVID-19 infection and quantify its extent, and especially monitor it over the time at the bedside, avoiding the carrying out of the patients along the hospital. And going to conclusion, these are results of European survey of the Pediatric Emergency Medicine Network about the dissemination and use of point-of-care ultrasound by pediatricians in Europe. And I want to focus in particular on barrier and limitation to the implementation of point-of-care ultrasound. And the same is for our Italian survey that we have at the end of last year. Participants was pediatrician, pediatric residents was in different hospital structure, in different settings. And although 90% of cases, clinical ultrasound was considered quite to very useful as an additional element to the clinic, the lack of certified training path and the few availability of machinery make it still little practice, too little practice. And both the European and the Italian experience show that the greatest obstacle to the use of ultrasound by the clinicians is the lack of an institutionalized training course, which certifies the skill achieved to guarantee both the doctor and the patient. And so, as Professor Colon explained, we need learning and schooling to achieving competence and to better have credentialing in pediatric emergency medicine faculty in point-of-care ultrasound. And thank you for your attention.
Thank you, Anna Maria. Two quick questions for you. Well, three, I think, because Jacopo may have one. Do you want to start, Jacopo?
Okay, I'm very interested on this presentation. And my question is, when I was younger, I'm a trekker. I'm very passionate of Star Trek. You know, there is a doctor, Dr. Leonard Nimoy, okay, and have a tricorder for visit his patient. So how many times you think that the POCUS have low cost for use POCUS instead of stethoscope? Because I think this generation in 10 years don't use stethoscope in their practice. You know?
So Anna Maria, yeah. So Anna Maria, one of the concerns is that if we get so used to using ultrasound, but we go to a situation where ultrasound is not available, will we lose our skills, our clinical skills, to diagnose without ultrasound?
I think that ultrasound is important only to complete. I don't like to imagine a young future pediatrician or pediatric emergency or emergency medicine without clinical evaluation. I don't like to imagine this situation. I like to imagine clinical evaluation and ultrasound evaluation together.
That's a good. So it's not man versus machine; it's man and machine, woman and machine.
But my question is, that is better listen or see?
She says yes. It's better to both listen and see, and one is not against each other, but that they are working together to confirm or refute. Is that correct, Anna Maria? It's together, not against.
Yep, because I think when you are using ultrasound from yourself, this is the difference. When you are asking for an ultrasound examination by a radiologist or a cardiologist, and you are in another room and going on with another patient, and the cardiologist or the radiologist evaluate your patients, and you and your clinical evaluation and your ultrasound clinical evaluation. Okay, I like this term, ultrasound clinical evaluation.
Anna Maria, it seems as if some lower cost, more portable ultrasound tools are becoming readily available now. For instance, you showed us in the picture a cell phone connected to an ultrasound probe, a butterfly essentially, that could be used during COVID or other times. How much difference is there in the use of these simpler, cheaper forms of ultrasound compared to the echocardiograph machines that we are used to seeing in the hospitals?
Okay, for the ultrasound, the clinical evaluation, rapidly ultrasound, the clinical evaluation, small ultrasound machine are small and cheap ultrasound machine are usually better than expensive, especially big. A big ultrasound machine is not suitable for a clinical ultrasound evaluation. Not so suitable.
So for the quick and sort of widespread evaluation, you think that the simpler, less sophisticated tools are very adequate, like the butterfly type, not to advertise any particular type, but just the cell phone-based ultrasound technology. Is that correct?
According to my experience, I have not so different ultrasound machine, but I think that also with this little machine, the technology is good.
Do you agree? Then we'll move to Carolina's presentation.
I agree that the technology is moving forward very nicely with the images that are generated. One of the problems that the smaller devices have is that they don't have pediatric specific probes, so that the footprints on the probes are actually pretty large relative to our patient size. And so the images might not be as optimal as if you were using a pediatric probe. There are lots of differences in sizes from the formal echocardiographic machine, it's a big machine, to just portable, smaller machines, to those handheld machines. And all of those are getting better, and all of them are getting cheaper. And so I can very much foresee in the near future having those iPhone type of machines that are specific to pediatrics. It's not quite there yet for pediatrics, but it's probably, as Anna Maria said, it's probably good enough for the big questions and the life-saving questions that you might ask.
I think the evolution is very much analogous to the automated external defibrillators, which initially were only available in sort of adult size, adult algorithms, and subsequently have created probes or created electrodes that now automatically adjust to pediatric rhythms and pediatric doses. So hopefully the same thing will happen with the ultrasound probes. In the interest of time, let's move to Carolina Cassini. I hope she can speak now and be heard. Still not hearing you. Try again. Try.
Try to talk to the PC microphone, and you hear from the phone.
She may have to take her microphone out of her ear and just.
You hear and speak by microphone.
Now I can hear you. Yes. Beautiful.
Yes, but do you hear me now?
Yes.
Very good. Go ahead.
Perfect. Okay.
Start your presentation.
I'm ready. So, I will speak about the role of POCUS in respiratory emergency. I'm a pediatrician. I work in the ward of pediatrics of Sant'Andrea Hospital in Rome, and I started performing ultrasound in 2012. When after participating in a meeting, I got in love with this technique, and since then I use it, and I'm very glad to use it. So, lung POCUS may help in the evaluation of patients presenting to the emergency department with undifferentiated chest pain, shortness of breath, respiratory distress. And in pediatric age, lung POCUS can help in particular to diagnose pleural effusion, parenchymal disease, and pneumothorax. The probe on the thorax was considered, was supposed to be a taboo, because a normal lung full of air cannot be reached by ultrasound because the pleural line is like a mirror that causes total reflection of ultrasounds. But what happens when the mirror breaks? The broken mirror is the theory. So it occurs that the disease shows us what happens under the mirror, because the pathology lets the ultrasound come inside the pleural line that normally is like a mirror to ultrasound. And this is because of the lung paradox. By lung ultrasound can be detected everything that excludes a different percentage air from lungs. When we have 98% of air, we see normal A lines. 95% we started to see rare B lines. 80% compact B lines. 10% left of air, the thickening complete. And 5% we say the consolidation complete, like in atelectasic lung. And this is correlated by the clinical severity. How can we perform in the emergency room the exploration? We start with the general exploration in these lines: parasternal line, medioclavian line, armpit, and paravertebral line. And then we start with the longitudinal and with the, in particular, examination by longitudinal scans and by transversal scans. The standard imaging is this that we can see. We can see on our image at the left of the image, the cranial of the patient, and at the right of the image, the caudal part of the patient. And in the transversal section, we can see at the right of the image, the left side of the patient, and of the left of the image, the right side of the patient. Normal, we have normal repairs in the lung ultrasound, and these are the A lines. This is a normal lung. We can see the rib. We can see the pleural line and the A lines that are mirroring the pleural line, reflecting it on our image. The B lines, also called comet tails, appear in our ultrasound image like this, like a ring down, also called comet tails. They are a sign of deaeration. This is what we know now, because at the start, the first operators in lung ultrasound stated that B lines mean interstitial involvement, but this is not true anymore because B lines does not necessarily means that there is an interstitial involvement. Only it means that in that point there is not air, so not air. So the ultrasound gives this effect of ring down or comet tail. The number and the compactness is related to the clinical severity. Another findings very often we see are the zeta lines. These are like similar to B lines, but we have not to confuse the B lines with the zeta lines, because these are also comet tail artifacts, but they are very, very short comparing to the B lines, and they not reach the distal edge of the screen. Remember, the zeta lines are not to be considered pathologic. We can also have a very precise projection of lung slopes on the chest wall. This is very useful because when we find the problem, we can exactly localize anatomically the lesion. And this is very important and useful to us. Now, the normal pattern in ultrasound is lung sliding. We can see it longitudinal and transversal projection. And we can see the lung sliding, between the two pleural sliding one on the other. We can see in this imaging. And this in the other section. Another finding that we can meet when we scan the thorax of a boy or a girl, of a child, is the time. The time is not to be confused with a pneumonia, because it has a similar echogenic presentation, but it's important to localize anatomically to see that is on the big vessels. And if we use color Doppler, we see that it is not consolidation, but is the gland, the time that disappears at 5 years of age, and it's very common to see in infants. Well, what happened in the evaluation for pleural effusion? Lung ultrasonography has been shown to be superior to chest radiography in the detection of pleural effusion, with a sensitivity and specificity of 92% and 93% respectively. Normal pleura is 0.2 to 0.4 millimeter thick. We can use the probe and scan dependent areas of lung, and we can assess the pleural effusion. The patient position for detect pleural effusion can be two. One, recumbent, which usually allow for the majority of lung tissue examination, and also the upright sitting position. This will allow one to easily quantify the severity of the fluid space by evaluating the distance from the diaphragm and lung parenchyma. If the distance between the lung and posterior chest wall at the lung base is greater than 5 centimeters, one can predict that at least 500 milliliters of pleural fluid can be drained safely. So this is like my colleague said before, we can pass to from the diagnosis to the therapy. So we can drainate fluid effusion. Therefore, 5 centimeters is a good cutoff point when patients may have significant pulmonary improvement after thoracentesis. We have some way to estimate the effusion volume. One is to consider the distance between the pleura and the lung tissue, and the volume in milliliters is 16 for the diameter in millimeters of the distance from pleura to lung tissue. It's very useful to use POCUS and lung ultrasound to detect pleural effusion. Imagine that X-ray allow to identify amount of liquid starting from 50 or 100 milliliters in orthostatism. But ultrasound identifies amounts of liquid starting from 20 milliliters. And this is an advantage because we can detect very early effusion. Another way to estimate the liquid amount in pleural effusion is to measure the thickness of effusion in the maximum interpleuric distance. So up to 3 millimeters, we can estimate 15 to 30 milliliters. And we can, from 3 milliliters to 10 millimeters. The liquid estimated is to be 75, 100 milliliters, till we got to 5 centimeters, we can arrive to 1.5 thousand milliliters. And this is how we see the pleural effusion. I'm sorry, but I'll show you again. I can come back. With the pleural effusion, we can see that between the two pleura there is the fluid. Another useful tool is to evaluate the how the effusion is changing in the time, because if we see the signs of initial emphysema with the fibrina trachis inside the effusion, this means that it's time to be to do the drainage, because this effusion is turning to emphysema, and this we can see in this image. We can see flattening the fibrina inside the fluid effusion. This is a sign of initial emphysema. Look what happens when the emphysema organizes and the fibrina branches grows and start to grow in rooms, separate rooms. And this is very important because when we make the drainage, we can maybe we cannot drain all the liquid because we find a branch of fibrina, and then it is important to use the probe and the ultrasound to do this drainage. And when there is this sign, it's important to make very quickly the drainage, because it is a rapid evolution with emphysema and sepsis. We can also distinguish from transudate and exudate. If there is a trauma, the exudate is to be referred to hemothorax, and this is very important, because if the child arrives to the emergency room with a pleural effusion with this consistence, we can imagine that there is an hemothorax, and this is important for the prognosis. Okay. When we have the pleural effusion, we can use the probe even to guide the procedure of the thoracentis. And so we place the needle above the rib at the level of the pleural fluid, and we can easily drain the effusion. What happens in the lung parenchyma disease? In the thickening consolidation happens that the disease, as we told before, reveals the lung. It's like an apple. What is down comes up and discover what there is in the deep region. Then the probe is placed on the chest, and there are multiple ultrasound beam reflections, and we can see the parenchyma down the probe. And with ultrasound, it's possible to make the differential diagnosis between atelectasis and consolidation, because in the atelectasis we see conserved the parallel chords of bronchograms, and in the thickening or consolidation we see arboriform chords of bronchograms, and this is very important to differentiate atelectasis from a consolidation. These are other findings in the lung consolidation: the fluid bronchogram, the aerial bronchogram, and these typical hyperechogenic spots. This is very important for the follow-up of disease, because we can see the evolution of a disease. If we see that a consolidation presents a lot of hyperechogenic spots inside, this means that this process is going to recover, because air is penetrating the inflamed region, and air is coming. This means that the consolidation is recovering. Also, we can see some vessels, and we can detect it usually very, very easily with the color Doppler. And this is how appears consolidation. Do you see the spots, the hyperechogenic spots inside that we were talking before? And another important application of ultrasounds in the emergency room is to detect evaluation of pneumothorax. And look, ultrasound has a higher sensitivity than traditional upright anterior-posterior chest radiography for detection of a pneumothorax. What happens when a pneumothorax occurs? Air, even if it is spontaneous or traumatic, air is penetrating the space between parietal and visceral pleura. And so the air make a total effect of a mirror. And so ultrasound cannot penetrate down, and B lines disappear. Look, this is a schematic view. This is the chest wall. This is the normal situation with the visceral and parietal pleura sliding one on the other. These are the normal comet tails that we see in the normal situation. But what happens when the pneumothorax occurs? It comes air between the two pleura, and we cannot see anymore the B lines down. Also, we can see a very important finding, which is the lung point. The lung point is the point until which we see the sliding between the two pleura, and then we don't see it anymore because air has penetrated. The lung point is the very important finding in the pneumothorax sign in ultrasounds. To reassume, the sonographic sign of pneumothorax are the absence of lung sliding, the absence of B lines, and the presence of lung point. And then we can see, do you see in this video, I'm sorry if I repeat the image, the lung point is where you can see the sliding, and at a certain point you don't see it anymore. This is very easily to see. In the right part of the schema, you can see the two pleura they are not sliding anymore. And this is another short video that is showing this situation. Even in the motion mode, we can detect the importance of pneumothorax. In the normal findings, we have the classical seashore sign. This is normal findings where there is not air between the two pleura. This is the finding in the B image, the finding of pneumothorax, because we can see the typical barcode sign. You see, it seems like a barcode, and this is the finding that we have a pneumothorax. Also, with the M mode, motion mode, in the figure C, we can see that there is the line point, which is the area where half part of the pleura is sliding and the other half is not. Okay, this is the chapter I wrote in the EART's Handbook of Respiratory Medicine 2013. And just I wanted to show you just the results of a work that I made on COVID in our emergency room, but in adult patients. I don't want to annoy you, but just to show that we made this work comparing ultrasound with tomographic thorax, and we had very, very nice results because they are their sensitivity is the same, and so this is the score that we used. Normal finding, more than 3 lines, white lung, and consolidation, the score that we gave. And we found out that a very important correlation between lung ultrasound and CT scan. This is important. And also, this shows that the most frequent typologies were the presence of white lung with superposition of lung thickening. And these are the findings of our patients in the emergency room. You can see here like very coalescent B lines. And also in this finding, this patient had mild interstitial involvement. And in this case, we have consolidation under the pleura, typical initial sign also of interstitial involvement. Even in this image, we can see the consolidation under the pleura, and together the coalescent B lines. Okay, and these are other images showing consolidation with a lot of B lines showing like a sign of white lung. This is with a convex scan, another image, another video of a patient with severe involvement of interstitial compart. And this is a pleural effusion. You can see in here the flattening of the part, the atelectasic part of the lung, which is like flattening in the pleural effusion. And these are other findings of pleuric, under pleuric atelectasics and consolidations in a patient with COVID disease. Okay. In conclusion, the use of POCUS in the department emergency department has grown over the past 2 decades and has evolved from basic use to include more advanced application. The advantages include, but are not limited to, improve the diagnostic accuracy for certain complaints, decreasing length to stay in the ward, improving patient satisfaction, improving procedure success rate, and decreasing procedure complications rates. Anyone practicing in this day and age in a center with POCUS availability has little excuse to justify not utilizing these powerful resources for the best of their patients. Thank you very much for your attention.
And while Thomas is loading up his last set of slides, so you indicated that you can differentiate pretty well between air, say pulmonary edema fluid, bloody fluid, and consolidation, say pus. How easy is it for the relative novice or the intermediate ultrasonographer to differentiate those different fluids, say in a pleural space?
Thank you for your question, Vinay. Obviously, it is not easy at the first time. It's important to have to make formation and to make courses to have the knowledge, but also to have the practice and to do to perform POCUS together with an expert operator in order to learn to differentiate these realities. The first time it's not so easy to differentiate what lies under pleural effusion because the consistency of the fluid is not very useful. Easy to differentiate at the very first stages of your practice in ultrasound. But if you go on practicing your POCUS, always I say after course and together with an expert operator, you will manage to do that. Sorry, I don't hear you.
Say
I didn't hear the question.
Thomas, I don't know if you were able to hear the question. No?
No, you cut out for those of us that are online for a little bit.
Carolina?
Yes.
Is there any specific trick or technique that you find very useful to help differentiate, say, blood from thick pleural fluid?
Well, the blood appears more hyperechogenic than fluid in my personal experience, but it's not always easy to detect. In this case, it helps the history, because if you are making ultrasound in a patient with a trauma, you can imagine that this is blood. If it is a septic patient, you can, so it's important even the anamnesis, I think. But with experience, you can arrive to distinguish these two realities.
Thank you very much. Again, you're pointing out that it's not one just physical exam or history or ultrasound, it's all of them together that's helping to make the right diagnosis.
Yes.
So now, Thomas, I'm going to warn you that it is about 7:20 in the evening in Italy, and it's really, really warm in this lecture room. So I'm going to challenge you for the next 15 minutes, if you can, make sure to make it spicy, make sure to keep us awake, and to take it away and tell us a little bit about shock and how ultrasound can be used to improve our management of shock.
Sounds great. I will make this extremely interesting to everybody. All right. So I am going to sort of build off the lung ultrasound talk and talk a little bit about how we can look at the heart and some of the vessels to assess patients who present in clinical shock. So the objectives of this talk are to discuss how bedside ultrasound can actually help in identifying not only the physiology of shock, but also possibly the etiology in cases of undifferentiated shock. We can also identify the goals of hemodynamic assessment, training within all of our clinical specialties in pediatrics. So I think everybody knows from medical school that shock is a state of circulatory dysfunction where we're unable to deliver sufficient oxygen and nutrients to meet the metabolic demands of our end organs. And while a sentence describes shock, shock is really a physiology of a bunch of hemodynamic variables that come together. And we know that they come together in some specific ways. We know through equations how we get oxygen delivery, how we get cardiac output, and by graphs, how that cardiac output can change with differences in inotropy. We also know that our physiology has goals. We have end organ oxygen delivery and end organ tissue perfusion as the ultimate goals of our underlying hemodynamic variables. And when we describe shock, we specifically describe abnormalities in some of these variables. For example, obstructive shock is a problem with our afterload condition. Cardiogenic shock, a problem with our contractility. Hypovolemic shock, a problem with our preload. And distributive shock, a problem with our vascular tone. So how do we currently look at shock at the bedside of our patients? Well, we have a lot of different data, from our clinical exam to our laboratory values to the monitors that are around us. We have data everywhere. And some of that data is very precise and specific. I can measure a hemoglobin level. I can look at a heart rate on my EKG monitor. But some of the ways that we assess our patients are indirect. I look at preload by feeling for a liver edge, by doing a straight leg raise. I can look at my perfusion by flicking a capillary bed. Some of the things that are very important in assessing a state of shock, such as contractility, stroke volume, and cardiac output, are oftentimes very difficult for us to understand by a physical exam alone. Without knowing those variables, we still try to treat patients who present in shock. And we have a lot of different algorithms from a lot of different societies that try to teach us how best to manage patients. This is an American College of Critical Care Medicine guideline on shock treatment from a few years ago, where it tells us that within the first 5 minutes, we should be providing fluids to all of our patients in shock, up to 60 milliliters per kilogram, until we have improved perfusion. If we don't have improved perfusion and continue to be hypotensive, we call that fluid refractory shock. And we start our epinephrine or norepinephrine within a 15-minute period of time. And we decide what medication we're going to use based upon whether a patient clinically has cold shock versus warm shock. And if we still have a patient that has what we term catecholamine-resistant shock, in 60 minutes, we are allowed to use what's called advanced methods of hemodynamic assessment, which includes ultrasound. Now, I personally think that this is backwards, because these 3 patients are all patients who present in shock, and they look very similar to one another by physical exam, by monitoring, and by laboratory data. But I would argue that all 3 of these patients have a very different underlying pathophysiologic process that requires timely and targeted therapies to optimize their outcome. Now, you don't have to be a cardiologist to see that there's a difference in these 3 patients and their parasternal short axis views. At the top left, the left ventricle, or that donut that's in the middle, looks like it's squeezing really well or hyperdynamic. In the bottom middle picture, you can see that the left ventricle is collapsed, indicating increased right ventricular pressure, or possibly pulmonary hypertension, or a pulmonary embolism. And on the right is a left ventricle that's not squeezing very well, having cardiogenic shock. Now, most of us, most of you in the room right now, are not cardiologists. But I want you to know that that's okay, because we have a lot of literature that tells us that when we ask focused questions that have evaluable answers, that we can be pretty good at getting those answers. And we can learn how to answer those questions with short periods of training. We can learn to be as good as cardiologists in our assessment. Now, without going too much into the literature, here are some of the basics of what we know about ultrasound and shock. We know that across disciplines, whether in adult medicine or pediatrics, that it introduces new data. We have far more patients who present with cardiac dysfunction as a manifestation of their state of shock than we originally thought. And this is being seen in many different patient populations, whether in sepsis, pediatric traumatic brain injury, pediatric cardiac arrest. We also know that ultrasound changes our management. We will titrate our pressors and our inotropic therapies in a different way when we have ultrasound data. And we find ourselves shifting away from fluids, which I think has beneficial outcomes for patients, knowing that many of our pediatric patients are fluid overloaded, which results in longer-term harm. And we believe that ultrasound improves outcomes. And while there's only growing data in this area, we know that those outcomes can be seen by providers, by patients, and by institutions in different ways. So how do we define shock using ultrasound? And I want to use similar terminology to what we're used to in bedside assessment: hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. When we talk about hypovolemic shock, what we are looking for in our patients is a patient that is fluid responsive, meaning that if I give the patient fluid, I want to see that I am increasing their cardiac output. These patients typically have normal contractility, and on their Starling curve, if I give them that volume, their heart can handle it, and it will augment their stroke volume, thereby improving my blood pressure and my perfusion pressure to my organs. How do I identify patients who might be fluid responsive? Well, one of the ways is because I can look at the large vessels within the body. This is a transverse view in the subcostal space, where on the left side of the screen, I can see my inferior vena cava in a cross-sectional view, and my aorta on the right side of the screen. And I can look at their size difference. And I know that in a spontaneously breathing, healthy child, that my inferior vena cava should be a little bit bigger than my aorta, approximately 1.2 to 1 in their ratio. And I can look for respiratory variability on the long axis view of the inferior vena cava. On the picture on the left, you can see the right atrium, the inferior vena cava, and the confluence of the inferior vena cava with the hepatic vein. And I can actually measure the changes in the contour of the inferior vena cava and the diameter on the longitudinal view to assess whether or not my patient might be fluid seeking. There are cutoffs in pediatrics that we typically use to identify fluid responsiveness looking in this view. Here you can see pictures of patients who have respiratory variation, one with a relatively large IVC or inferior vena cava on the left, and one with an extremely small inferior vena cava on the right. And putting these together with a picture of my heart, I will feel much better about giving fluid to patients who have collapsibility of their inferior vena cava. Here we can see pictures of inferior vena cavas that don't have respiratory variability. They may be preload sufficient or have enough volume in there already, or there might be some cardiac dysfunction upstream of the inferior vena cava that I need to assess. So when I put these together and I describe the physiology of hypovolemia using ultrasound, I would see a patient that has IVC respiratory variation and complete collapse on the left, as well as hyperdynamic ventricular function seen on one of my cardiac views. Here, an image of a parasternal long axis. But not only does ultrasound help me to understand the physiology of shock, but it may give me clues to the etiology as well. Here is a patient with blunt abdominal trauma who has blood in their abdomen. And here is a postoperative cardiac patient who is seen to have hemorrhage in their thorax. Now, we can also assess for cardiogenic shock by looking exclusively at the heart. Again, you don't have to be a cardiologist to see that in this parasternal long axis view on the left, that you have severe left ventricular dysfunction. There is barely any volume that's getting to the systemic circulation. You can compare that to this middle picture where you see moderate left ventricular dysfunction. And you can compare both of those to the picture on the right where there is normal left ventricular function. You can train your eyes to differentiate between these important distinctions. It does not take long to learn about how to diagnose cardiac dysfunction, especially in the spectrum of severe and moderate dysfunction. And this is relevant because it also helps us to identify the potential etiology of your problem as well. On the left, you can see a picture of a patient who was initially diagnosed with bronchiolitis, but obviously had cardiomegaly on their x-ray. And when you put a probe on their chest, you find a massively dilated left ventricle that had poor function. And ultimately, that child was diagnosed with a condition called Al-Kappa, or absent left coronary arising from the pulmonary artery. Now that we are using novel immunotherapies and targeted therapies for various disease states, we can see myocardial dysfunction from what's called cytokine release syndrome. And we also know that cardiac dysfunction is an important component within post-cardiac arrest. So again, incorporating ultrasound findings with the clinical context of your patient to arrive at an etiology for your cardiac dysfunction. You can also diagnose obstructive physiology using ultrasound. On the picture on the left, you can see a dilated inferior vena cava and hepatic vein. And on the right, you can actually measure your right ventricular pressure by looking at continuous wave Doppler and performing quantitative assessment. And again, you can identify the etiology, putting things into clinical context. Here you can see consolidated lung behind a normal functioning left ventricle, but with a dilated right ventricle in a patient with ARDS. Here is a patient peri-arrest who has a large right ventricle, indicating a potential pulmonary embolism as the cause for their arrest. Here is a large pericardial effusion, and in a patient with shock can be diagnosed as having tamponade physiology. And a hypoxic patient who presents with a pneumothorax can present in shock as well. Distributive shock is in many ways a diagnosis of exclusion. What we find in these patients are normal preload conditions or IVC measurements, normal contractility, and no evidence of obstructive physiology, yet they are hypotensive and tachycardic with poor end organ perfusion. So each of these terms, each of these definitions of shock, hypovolemic, cardiogenic, obstructive, and distributive, are amenable to ultrasound interrogation. And again, placing them into the clinical context may modify what you do for your patient and, in time, may improve their outcome. The other nice thing about ultrasound is that it's not just one time that you need to use it. You can use it many times. And it's important because we know that shock physiology will change over periods of time. This is a patient who presented in shock, and within 12 hours of our management of this patient, you can see that the right ventricle, which is to the top right of this, or excuse me, to the top left of this apical 4-chamber picture, is very different over that 12-hour period of time. It is now dilated and dysfunctional. Once we initiated nitric oxide and started the patient on epinephrine, within 1 hour, we're able to see actually an improvement in the right ventricular performance. I think there are 4 main things that we can look at as a critical care physician or as an emergency medicine physician that are important and relevant to how we define patients in shock. First, using ultrasound, we can interpret our preload conditions using clinical and ultrasonographic data. Second, we can identify the presence of a pericardial effusion, and in the clinical context, determine its hemodynamic significance. We can also assess for left ventricular and right ventricular function, and we can characterize ventricular size relationships to identify abnormalities that might be consistent with pressure overload conditions. That concludes my talk, and I am happy to take any questions that you might have.
Well, thank you to the 3 of you who are really leaders in the field of pediatric ultrasonography. And you've taken us on a whirlwind tour of how POCUS can be applied for respiratory emergencies, for shock states, that we are in some ways ready, maybe more than ready, for the application and the dissemination of training and sort of certification and appropriate use. I'm going to see if there's anybody here in the audience who has questions for any of these 3. We'll pause for a moment. Is there a question here?
No, maybe it's not a question, but a consideration,
comment, yes.
Comment, yeah, because
I'm going to repeat it after you say it, so I'm sure that they can hear it.
okay, okay. Right.
She's coming to the microphone for a second.
Hi. No, I think that the ultrasound, the POCUS in general, is a technique very useful in pediatric and neurology, and maybe something that need in our instruction in these 5 years of the pediatrician is maybe a course, something that consent to everyone to learn to use it, because it is a technique, so we need experience, we need to use it in every condition. So maybe we have to think about some kind of classes in these 5 years to do this, and when we finish the specialization, can do more comfortable when go to work in real life. So I think that it's important for us that maybe it's
So maybe you can each take 1 or 2 minutes, just 1 or 2 minutes, to say when students or residents are exposed to ultrasound training and the relationship of courses in ultrasound to continuous review and a more continuous stream of education. I'm going to start with Anna Maria at Bambino Gesù. You know, I think, both the American and the European conditions. When is it that you think that either medical students, residents, fellows, attendings should be exposed? And what's the relationship of courses and continuous feedback and training?
I think some frontal lesson, maybe during the students, when they are students, and then during the fellowship, all 5 years. We begin something like this in Università di Tor Vergata University, with some fellow, and we begin from the first year. Then COVID arrives and we stop, but we have maybe 5 webinar about lung ultrasound. And then when the fellow come to the emergency department, they try with me or with my colleagues, they use point of care ultrasound and lung ultrasound. But the most important experience is when they begin to use. And they begin to use, but they need some tutoring. I think the most important thing is tutoring time.
So Thomas, I'm going to ask you to describe a little bit, perhaps, your tutoring system that you're using. And then, Carolina, I'm going to come to you to ask you a little bit more specifically about San Andrea and any plans or any ways that you could see this being integrated into the residency program. But first, Thomas, if you could just mention a little bit about how you're approaching this.
Sure. So in the United States, many medical students are now getting exposure to ultrasound. It is not consistent across all the medical schools. And so we, in critical care, pediatric critical care, will start from the basics with our fellows. We will have them take a 2-day course to start off with their education. And then once they're completed with the course, they can then perform studies in our intensive care unit on patients. Typically, we will have somebody who is credentialed, a faculty member, who is working with them. We try to provide them direct oversight as a clinician overseeing their studies, but we also don't want to stop them from what we think is an important part of clinical care in performing ultrasounds. And so they will perform ultrasounds and they will document them in the patient's medical record. And we have a way, so I, as a clinician, will oversee all of the studies that go into the medical record and make sure that they are interpreted the right way. If anybody finds something that's abnormal on their assessment, then what we have them do is have a gold standard either study that's also performed or consultation with a specialist. So we in critical care mostly perform cardiac and hemodynamic studies. So if we find an abnormality on one of our studies, we will call a cardiologist to either assess the patient or perform a complete echocardiogram. But all of this is with the oversight of credentialed physicians, either direct supervision or indirect supervision of our trainees.
Thomas, is there a way for the trainee to store their image and store their decision that then gets reviewed in a quality improvement kind of method?
There is. We have our machines directly connected to our electronic medical record so that our images are stored in what we call a PACS system, or stored in a system where all the radiology studies are stored. Providers have an ability to place their interpretations and are asked to place their interpretations in a separate online data set. And then we will review those interpretations and put in official interpretations into the medical record along with the pictures. So there is a way for them to do interpretations that don't go into the medical record themselves. Only a credentialed physician can place those interpretations. And so we developed a system, but it does take time and coordination to develop such a system.
I'll just mention that I think this allows the trainee to extend themselves, to go ahead and make a guess, to make it, it forces them to make their own interpretation at the point of care at that time, to give the treatment that they think they should based on their clinical exam and their ultrasound exam, and then to get feedback later on in an organized fashion to either compliment them on their excellent assessment, or to identify an opportunity for improvement, or an artifact that might have been misinterpreted that could be interpreted the next time better. Carolina, can I ask you sort of to finish up with maybe the situation at Sant'Andrea, and to say, are there plans, are there ways that this could be incorporated systematically into the training of the residents?
For the question. It is my hope that this skill is introduced in the training in the residents. I am organizing some courses. I have organized 3 since now, and there is one in program just for residents in November in Sant'Andrea Hospital. It's a course of 2 days. They will have frontal lesson, but also one entire day in the pediatric ward and in the neonatal ward in Policlinico Umberto I. So they will have the chance to try and to exercise. And in my experience in the world, there are some residents that are particularly interested in the ultrasound, and so they are always near to me. They follow me in the world when every day we perform lung ultrasound for pneumonia or for patients in the world, but they also follow me when I go in the with my personal probe that I bought. There is no advertising because there is no no brand. It's my personal probe. They who comes with me in the calls know that I go together with my probe. That it's the continuation of my stethoscope.
Terrific. Well, I want to thank the 3 of you for taking the time this afternoon. It's really been helpful. It's a great start. And Jacopo, anything else to add as we close?
So I have only to say thank you to everyone that participated to this beautiful webinar, or live webinar, or also presence. And thank you. I'm waiting for you in November, Thomas, for the Carolina course you organize.
Sounds great. I'll see you then.
Yes, sir.
And I think the residents should also know that there's quite a lot of collaboration going on between many of the Italian sites and CHOP and other sites in the United States. But it's really you guys are the pioneers, and you're really a small community when it comes down to it. And the importance of the exchange is really important, but it also gives opportunities for the residents, as you said, who are interested to be able to piggyback, jump on the back of that collaboration and get some experiences outside of their own institution. So thank you all. Appreciate it.